thank you very much for quoting it, but also about the fact that I was given a very difficult task, as you see, at the crossroads of science, ethics, and public health. And my disclosure is, who am I to tell you about this? What we've heard in the past 3 days has been the enormous wealth of knowledge and experience that is present in the countries where sickle cell anemia is a major public health problem. And I'm nobody to tell you about this. I will just try to express what I feel, because in Greek, sickle cell is drepanocyte, and my only claim is that I am somebody who has had experience in comparative drepanocytology, because I have been licensed to practice medicine in 5 different countries over my lifetime, and in every one of them I've looked after patients with sickle cell anemia. So I thank the organizers, and particularly Dr. Isaac Odame, for giving me this challenging task. The paradoxes of sickle cell anemia are very well known, and they can be phrased in different ways. We all know it was the first molecular disease, but safe, effective cure has been elusive. It is monogenic but highly variable, not only among one patient and another, but even within the same patient. It is a blood disease, but it can affect all organs, and we will hear in this session particularly the central nervous system. It is not anemia, but pain that is the most frequent clinical problem. So I will try to touch on all these aspects in different ways. In 1989, with Peter Goodfellow, we had simply to admit that it was a simple disease with no cure. As a matter of fact, this was the journalistic title given by Nature, because we already knew that bone marrow transplantation could be a definitive cure, as it was shown almost immediately by the Belgian group. In the meantime, I like to show you the very close chemical relationship between compounds, because we had a false start on high-dose urea, which I don't even want to talk about. We've had another false start with cyanate, with the wonderful work by Tony Cerami and Gillette, who abandoned it when they found cyanate was too toxic. And it's closely related to hydroxyurea, which I will not repeat, because Mohan has already showed this, actually important, I would say, groundbreaking result of the experiment of the trial run by Sharash and collaborators. So since then, at least, we've had one approved drug for sickle cell anemia. The question of genetic variability, which had been only linked to alpha thalassemia for decades, took a new stride with the genome-wide association studies, and I will skip this because Mohan has already told us about this. So when it comes to what should be the what I call the public health ethics agenda, these are all topics that I will not be able to cover in detail, but the advantage is that some of them have already been abundantly covered during this Congress. Awareness, patient empowerment have been protagonists. I was really very impressed by all what we heard from sickle cell patients, including yesterday a really powerfully touching account of a patient who told us about her struggle to have children and her relationship with her doctors, and particularly with hydroxyurea. I found it really elating. Some of these aspects have already been touched. And I will concentrate on only 2 or 3 of these, especially as public health relates to ethics. So it also relates to science. For instance, population structure affects the frequency of sickle cell anemia. I don't know if you've noticed that in all the projections and calculations that are made in the United States about the frequency of sickle cell anemia over the next couple of decades or so, the assumption is made that the next generation will be the offspring of a particular subset of the population, African Americans, and from that the calculations are drawn. I made some calculations which I do with students that I don't have the time to show you in detail, whereby if there was completely open reproduction, completely open interbreeding, the frequency of sickle cell anemia in the United States in one generation would drop by a factor of 10. That is the interface, not just of public health and science, but of society. And I don't know if you've been struck in the slide that we saw many times, and therefore I don't repeat it, where India is one of the 3 most affected countries by sickle cell anemia. The whole of India is shown in red with this distortion. But I don't know if you were impressed that Dr. Inusa yesterday, who is an expert on sickle cell anemia in the UK, and he told us that in UK, although he's tried very hard, he's never found one person. There are about 2 million people of Indian origin in the UK, and he has not found sickle cell anemia. Why is that? Well, because of course, sickle cell anemia in India is not uniformly distributed. It is highly localized, and to a large extent, highly segregated. So it is a bit misleading to show India as it is shown. In fact, it is population structure that makes the frequency in certain particular subgroups so high. Coming further to the interaction between public health and the ethics agenda, we will hear a talk on prevention by prenatal diagnosis and genetic counseling. And in fact, I think this has been a recurrent theme, and yes, we must think, but we must think it through. Genetic counseling is all very well. In fact, it is compulsory, but Dr. Sargent has circulated a very interesting paper in which he showed that in the UK, where they did this in great depth in one particular community, there were 5 instances whereby AS marriage on fully informed, one of the partners was fully informed, and yet it happened, and the result were homozygous SS children, in spite of all the effort that had been genuinely put in by a large number of health workers. So genetic counseling without prenatal diagnosis and consequent option to the couple to have pregnancy termination has in general not been very effective. I told an anecdote to some friends last night. When I was in Nigeria, I had a student who knew he was AS. He brought his girlfriend to test, and she was also AS, and we did counseling, and I was very struck by how cold he was in telling me that he is finished with this girl. I was really impressed as a geneticist, but distressed as a human being. And fortunately, 6 months later, I was invited to the wedding of those very 2 persons. So I was not a very good genetic counselor. Hydroxyurea, we've heard a lot about that, and I've said it is very important that we make it available to all those who need it. The mechanism of action of hydroxyurea we've also heard. It is more complex than it meets the eye. This is, I think, a very interesting paper in which they showed that the group of Buhassira at Albert Einstein in New York showed that it actually affects the hemoglobin F increase at the individual erythroid colonies in vitro level. And what I found very, very interesting is that different individual clones have different sensitivity to hydroxyurea, and he localized this to the question of, you see the variability in these two different experiments, and what it means is that it is a question of the exact time in the differentiation of the erythroid cell when the hemoglobin F is turned on. So I'd like to tell you a lot more, but you've heard a lot about hydroxyurea, and crizanlizumab is a bit of a tongue twister, but I will learn gradually, and it is, I think, very important, this trial, because it is the first after hydroxyurea that shows, and it links directly to what we just heard from Dr. Nairla about the question of adhesion molecules. Here you can see the result, very recent, on the frequency of the first painful crisis, and after continuing on the frequency of the second painful crisis while patients are on crizanlizumab. And of course, this is not an approved drug yet. I think what is very important, once again, it acts on pain. And I've emphasized that is main clinical problem. And I think it is very intriguing whether it will be possible by the combination of this with hydroxyurea to decrease the dosage of either or both. But of course, as doctors, we would like definitive treatment. And at the moment, it is very interesting that definitive treatment is possible with allogeneic bone marrow transplantation, but two considerations are fundamental. One was already made by Mohan, and that is cost. The cost of bone marrow transplantation is regarded as astronomical. It varies in different countries from $100,000 to $300,000 on the average, but I know that in India the price can be much lower. However, what I find very interesting is a second important consideration, that even in highly developed countries, only a very small minority of sickle cell patients choose, or at any rate undergo, bone marrow transplantation. There are a variety of reasons for that I will not go into, also because many experts, including Dr. Hene Frempong, know a lot more about this scientifically and personally than I could convey. But what I do like to show you is this slide, which I owe to the courtesy of Professor Nozakahare Bazwaye, who is in Benin City in Nigeria. And these are the data on 3 patients who have undergone bone marrow transplantation in Benin City in Nigeria. And all 3 are alive, and 2 of them are fully recovered. One of them has had what is called a rejection with full autologous regeneration. And this patient is particularly interesting because he has very high fetal hemoglobin, and at the moment, 3 years after the transplant, he still has high fetal hemoglobin, which protects him from sickle cell, from practically most manifestations of sickle cell anemia. So it is very interesting that one particular aspect of bone marrow failure, of transplantation failure, can be beneficial. Actually, this had already been reported some 20 years ago by the Belgian group who initiated allogeneic bone marrow transplantation, and they found that in 3 cases with autologous recovery, there was high level of hemoglobin F, and I recently had correspondence with Dr. Alina Förster to ask her what has happened to these patients. And she told me that for several years they had high fetal hemoglobin protecting them from painful crisis. Unfortunately, subsequently, the fetal hemoglobin tailed off and they now are on hydroxyurea. So the question of gene therapy has been raised by Mohan, and I'd like to just very briefly take you through this, because it is a scientific development which may affect public health. And of course, as you all know, there are essentially 2 forms of gene therapy in the sense of how gene manipulation could help us to cure a disease. One, we could call it gene addition. That is, here you have the person in the genome who's got the mutant gene. We leave that alone, but we introduce a correct gene, hoping that this will, as it were, overtake the adverse effects. And of course, you can immediately think that this will be more or less effective in recessive disorders or in dominant disorders. The other possibility, which from the outset I regarded as more attractive, is gene replacement. That is, you actually physically would like to replace the mutant gene with the normal gene. And in fact, the first approaches in this direction came directly from understanding it required a full understanding of the molecular basis of globin gene expression. And as you know very well, the beta globin cluster, this is the embryonic, the 2 fetal genes, the 2 adult genes, this is the famous locus control region, and this is the model that explains how it works. In the embryo, it loops out, and the embryonic are associated with it. In the fetal genes are associated with the locus control region. In the adult, it is the adult gene. So this looping of the DNA enables the locus control region to control at the various stages of life. And there are complex developmental mechanisms that make this couple instead of that, and in adult, this couple instead of that. So this was necessary, and the first experiment was successfully done in the mouse, when by coupling the pieces of the locus control region with the beta globin gene, Michel Sedline in 2000 reported the successful expression of human beta globin in mouse. But that is still an approach by which, as far as I know, so far, only 1 patient with sickle cell anemia has been treated by lentivirus gene transduction by the group of Marina Cavazzana Calvo, who reported this about a year ago at ASH, and also in Kampala a year ago at the sickle cell meeting. I cannot go, of course, into all the details, but I just want to show you the alternative. This is the same cluster that I just showed you. This is the beta globin mutation in red. And what you could do, and what has been done in a number of model systems, of course mostly in the mouse, is to target this region, to make a vector that will have homology to the DNA upstream and downstream of this region. So here you have a lentiviral vector which has these homologies. It is very, very similar to the endogenous gene, except it doesn't have the mutation. And by contemporary technology, it is possible to get this vector to actually undergo homologous recombination with the endogenous, and now here you have the cured gene by homologous recombination. So this has been successfully achieved for this particular gene in the mouse already. And the great breakthrough in recent technology over the past 5 years has been that there is a third approach, which goes under the popular name of gene editing. And I cannot go into the details, but what the gene editing means is similar to homologous recombination, but you are actually pointing directly, as you know, this is a single nucleotide replacement, and it is possible to literally go there and as if you were a very handy craftsman, that you are actually tampering with that and actually putting it right. And this is what is called gene editing, and it is not just an idea, because this is the beta globin cluster once again. And in a very recent article, and I don't want to embarrass Mohandas if I've highlighted the name of his daughter, because she's a co-author of this paper, and in which they've actually made a vector. Here are the three exons of the beta globin. Here is the S mutation, and they've made a construct that can actually get there and do precisely that fine manipulation that I've told you. And here you can see that the isolated clones deriving from hematopoietic stem cells, in which now there is expression of hemoglobin A in blue as opposed to S in red. So in vitro, in human cells, this has already been carried out. And another strategy, which I think is of extreme interest, is for years and years we thought if we can reverse the switch, we could still make fetal hemoglobin in an adult with thalassemia or with sickle cell anemia, and that probably would amount to a cure. And so this is another approach that has been explored by Dr. Mitch Weiss' group at St. Jude's. And here you can see that when they forced through gene editing, they removed a certain sequence which makes the switch possible, and they retain fetal hemoglobin synthesis. And here are look at this, they've isolated individual and photographed individual sickle cells. So I cannot say what will happen, but I can say that it would be an attractive possibility that although both allogeneic bone marrow transplantation and gene therapy are at the moment very costly, that there are a lot of attraction in gene therapy because all the immunological complications of allogeneic transplantation are out. And so I wonder whether developing countries may choose to skip that approach and to go directly to the gene therapy approach. To finish, Mohan has already mentioned about malaria and sickle. I will not go, this is my summary of how protection in AS heterozygotes work, but I will not go into that because I want to go back to the triple interface between science, public health, and ethics. And the reason it relates to malaria is this. The sickle cell gene has been selected by Darwinian evolution to protect against the scourge of malaria, against dying of malaria. So the survival of entire populations is thanks to the sickle cell gene. But the entire burden falls on the homozygotes. The heterozygotes are protected, but we have, in my view, a dual responsibility to the homozygotes. One is as doctors because we are here to treat patients. The other is because they are carrying the burden of the Darwinian selection that has made it possible the survival of these populations. So at this triple interface, we must still work hard. We must work on what is important. There is an enormous literature on sickle cell anemia. I still hear sometimes say, we know nothing about the, we have to find out what happens because we know nothing about the natural history. No, we know a lot about the natural history. We know a lot about the variability. Let's not repeat what is already known. Let's work on new things that are important. And the third point is health an industry or a service? And this, of course, would take not a lecture, but an entire session, an entire meeting. I will not go into that. I will just say we have to have a clear idea. Do we regard it as an industry or as a service? Well, where my loyalty lies is fairly obvious. I think health is a service. And we must learn the best from each existing health system, not the worst. And we must make hydroxyurea available. We must make blood products available. We must have every sickle patient have a diary. We must work as a team. I still hear somebody saying, no, we can't operate because the surgeon said the hemoglobin must be 11. That is not how you treat sickle cell anemia. We must be all together and confront the problem of that patient. And therefore, we must go from recommendations to implementation. We must establish effective networks so that all patients are treated where they are when they need it. And together with all stakeholders, we must still work very hard. Thank you.